So first and foremost is the patient history. I find it very helpful if you can get as much information as possible before you even meet the patient. Of course, their chief complaint, if it's a referral from an outside provider, it helps to look forward, a week beforehand, looking at your patients for next week, making sure you have all that information uploaded. And gathering that from a referring provider can give you save you a lot of time in the exam room. Having the patient perform or complete a review of systems and an incontinence survey can also be very helpful, giving you a lot of information even before you meet the patient. These can be completed at home. It can be mailed in to the patient. However, I find that oftentimes they try to fill them out the night before or forget about them. So sometimes having them come in a little bit early and completing them in the exam room is more efficient. The different types of incontinence surveys that can be used, the ICIQ SF is an international survey that's used for both men and women. This is really the most common survey used around the world for assessments. The urogynecology practices often use the PFDI-20, the pelvic floor distress inventory, along with the PISQ-12, which assesses women only for pelvic organ prolapse, incontinence, and sexual function. Two short forms that are very handy in assessing women are the IIQ-7 and as well as the UDI-6. So it's really just best to kind of get a handle on, reviewing all these questionnaires and deciding which one is the best for your practice. So the patient history, again, getting all the information you can before you enter the room is very important. The demographics, a complete list of their medications, as well as over-the-counter medications. And when you're looking at their medical history, some of the things I kind of zoom in on are things that might affect their bladder control, such as diabetes, high blood pressure. Someone with asthma or allergies might have worse symptoms of stress incontinence due to unmanageable allergies and excessive coughing. Those patients are also at increased risk of prolapse, especially if they're smokers. Does that patient have a connective tissue disorder? Those can contribute to incontinence, urethral hypermobility, and prolapse. Do they have an orthopedic history, any lumbar sacral spine issues, low back pain? Have they had an injury to their spine or pelvis? And of course, you're always looking for patients with the diagnosis of MS and Parkinson's disease. Those central nervous disorders can cause bladder control symptoms. Has the patient had a stroke in the past? Have they had sexual trauma? So these are kind of parts of the medical history that can lean towards maybe some bladder symptoms. Surgical history that might stand out. Have they had a urethral bulking procedure in the past? They have had hysterectomy. Was there any mesh used? Have they, what kind of prolapse repair did they undergo? And then weight loss surgery. Sometimes patients that have gastric banding or other types of weight loss surgery have some restrictions in their dietary intake that also might affect their bladder symptoms. Getting a good thorough gynecological history. Are they postmenopausal? Knowing that loss of estrogen can affect bladder symptoms. There's a lot of estrogen receptors in the bladder and the pelvic floor and the urethra. So really it's postmenopausal females are going to be more at risk of incontinence. And they have a history of endometriosis. Certainly scar tissue in the pelvis can affect their bladder symptoms. Any history of uterine fibroids. And then a real thorough obstetrical history, that's particularly vaginal deliveries with the largest birth weight. Was there any use of delivery tools such as suction or forceps? Those people are at increased risk of having a pelvic floor disorder or incontinence. And then a third or fourth degree tear. These patients are at risk of having posterior wall weakness. A family history can also be important. Connective tissue disorders are inherited, so someone can be at increased risk of prolapse or incontinence or recurring urinary tract infections based on family history. They're a smoker, that'll increase their risk of bladder cancer, as well as stress incontinence, alcohol consumption, recreational drugs, sexual history. And I love to ask the question, what do you do all day? Really getting a feel for the activity that patient's engaged in, if they're pretty sedentary throughout the day, or if they're living and working on a farm where they're doing a lot of heavy lifting. So that question is going to help really drive your treatment plan. And then really a detailed history of their lower urinary tract infection. So the next few slides we're going to go over are things that are on my intake questionnaire. Do you leak with coughs, needs, laugh, and lift? Really particularly asking them if they leak during intercourse is very important. You have urgency, frequency. Do you leak on the way to the bathroom? How often do you go during the day? How many times do you get up at night to urinate? And then, of course, the 3 common triggers for overactive bladder: changing position, oftentimes going from a seated to a standing position, key in the door, and sight and sound of running water. And querying somebody about if they feel like they're emptying completely. Oftentimes people with overactive bladder just assume they're not getting it all out, so they'll do all sorts of interesting things on the toilet, Valsalva voiding to try to squeeze out the last drop of urine. Positional voiding can be an indicator that they have maybe some vaginal wall weakness or prolapse, as well as perineal splinting. Sometimes people with rectoceles will often do that to help empty their bladder or bowel. And then post-void dribbling, urination, wiping, standing, and then leaking a little bit of urine with standing. History of urinary tract infections is very important. Whether or not they were culture positive is something that you want to definitely question the patient about. People that have pelvic floor dysfunction or high tone pelvic floor often have symptoms of a urinary tract infection. Maybe their clean catch shows leukocytes and they get treated. Whether or not they actually had one is very important to know if they have recurring UTIs. What type pad are you wearing? What size? How many pads are you going through in 24 hours? Are those pads causing irritation of the vulva, of the perineum? Just helping somebody find the right pad product can be very helpful. And then, of course, what's their average fluid intake? What are they drinking during the day? How many servings of coffee, water, soda? And really getting a thorough idea of how well they're emptying their rectum every day. That will, of course, influence their bladder symptoms if they're not completely emptying their rectum on a regular basis. How often do you have a bowel movement? Do you strain? Do you feel like you empty completely? If somebody has to wipe several times after a bowel movement to get clean, that's a sign that they're not completely emptying their rectum. And so those patients, you definitely want to focus on that repetitive wiping history there. So oftentimes those people benefit from bulk forming laxatives like Benefiber, Citracel, just to help to get it all out. Do you use positional perineal splinting to empty? And then a really important question is, do you ever leak stool? Oftentimes people are not going to volunteer that information, but they do want to let you know. Do you feel a vaginal bulge? Do you feel pressure? Do you feel discomfort? So you're trying to understand if prolapse or vaginal wall weakness is contributing to their symptoms. Are they sexually active? Do you have problems with intercourse, pain, dryness? Are they on vaginal estrogen cream? Are they able to climax? Do they have pain with climax? All these are really important questions to ask to help to evaluate their pelvic floor as well. And then, of course, do they have any vulvar symptoms, any irritation, any itching or burning on the vulva? That's a whole nother road to travel down. So you've got your fingers crossed that you don't have to go down that road. But it's certainly a big quality of life issue for women that have vulvar symptoms.